pause and project. school for those boys. So you take most of those cases are second to border, even in Bara, where everywhere, most of them are due to border accidents. You continue.
Yes, doctor, thank you very much. So, so going back a little bit on embryology of the brain and the head, we go back to the 3rd week of development, whereby we have the trilaminal germ layer, and that trilaminal germ layer undergoes folding, and that folding forms the primary vesicles, and then it forms the secondary vesicles, which eventually form the adult brain that we see. So in this slide, you can see the forebrain is has embryologic origin from the telencephalon and the diencephalon, as we shall see in the adult, as we can see in the adult brain. The telencephalon gives rise to the cerebrum, including the cerebral cortex, the white matter, and the basal nuclei. And then the diencephalon gives rise to the diencephalon structures, the thalamus, hypothalamus, and epithalamus. And then the midbrain, the midbrain comes from the mesencephalon, and it remains as the midbrain, which is a part of the brainstem. Then the hindbrain it gives rise to the metencephalon, which subsequently gives rise to the pons and the cerebellum, and then the melencephalon, which gives rise to the medulla oblongata, and also part of the spinal cord, which is not in today's discussion. So there is a picture of the head showing these respective parts that we have talked about. So talking about the gross anatomy, we'll talk about the gross anatomy of especially the layers of the scalp. We have, it is abbreviated as scalp itself, and on top of it we have the skin, which usually is covered by hair, followed by connective tissue, followed by aponeurotic layer, then loose areolar tissue, and then the pericranium. Those are the 5 layers of the scalp that we have to be mindful about. And this is important because when we have lacerations to the scalp, we have to make sure that these layers are repaired, or there can accumulate a hematoma in here and it can become problematic. The picture on the right shows the layers when you finish the scalp and you go inside. Yes, doctor.
Yeah, so on those layers that I've just mentioned, those 5 layers of the scalp, which one will be the most, like which one will be more wide?
The one which,
some people also, after getting this head injury, can lose significant amount of blood.
Yes, the skin and connective tissue, doctor.
Mm-hmm.
Skin and connective tissue.
Okay, Sebastian. Abubakar.
Yes, Prof.
Are those people there? Which area breathes the most?
I sing of areola. Those areola. And aponeurosis, because vascularized is highly vascularized.
So yes, so it is the loose areolar tissue that is, and also find they're very so intimate in that area. Find they are more elastic. So once they are traumatized, they tend to retract, and then you find someone what bleeding out from that cellular tissue. So it is the set for most of what subgilal hematomas, that cellular tissue among all those 5 areas. There also others bleed, but the most one is what? This cellular tissue once is what is involved.
All right, thank you.
Do continue.
Thank you very much.
Okay.
So when we are doing surgical toilet and stitching for these patients, it means we have to pay particular attention to the loose areolar tissue. So the picture on the right illustrates the other coverings after the scalp. We have the skull. Just below the skull, we have the dura, the meninges, which is the dura, the arachnoid, and the pia. So the dura is divided into two. There is the periosteal layer and the meningeal layer. Then just below the dura, there is the arachnoid, matter. Then below the arachnoid, there is the pia matter. So also there is a dural fold which is illustrated in this picture here, and the superior, which lodges the superior sagittal sinus, and it goes deep inside to divide the cerebrum, and this is called the falx cerebri. And it is going to be, we are going to see the significance where there is midline shifting and subfalcine herniations and so on. So it also lodges, so the subarachnoid area lodges the blood vessels which connect the brain to the scalp. So now looking at the skull bones, we have two parts of the skull. We have the neurocranium and the visceral cranium. So that is what is the cranium and what the facial skeleton is. So the skull has 22 bones, and of the 22 bones, 21 are fixed, and there is one which is movable bone, that is the mandible, and there are 8 paired bones and 5 unpaired bones. And the unpaired ones, we have the occipital bone, we have the ethmoid, we have the facial bone, we have the frontal bone, we have the frontal, we have the mandible, and the others. So they are connected to each other by sutures. The sutures are illustrated in the picture down here. So the two frontal bones are connected by the metopic suture, and then the midline suture which connects the two parietal bones is the sagittal suture. Then the suture which connects the parietal and the frontal bone is the coronal suture, and then these sutures meet in the midline, forming the anterior fontanelle. Then posteriorly, or at the back or at the occiput, we have the lambdoid suture. So these are the sutures which are illustrated in the picture here. So the bones, they are also illustrated in this picture. So talking about the blood supply, we'll talk about the blood supply to the scalp, and also talk about the blood supply to the inside of the dura. So for the scalp, it mainly derives its blood supply from the external carotid artery, which gives rise to these different arteries that supply the scalp. For example, you can see in this image illustrated the occipital artery, the posterior auricular artery, the superficial temporal artery, the parietal branches, the superficial temporal artery, the frontal branch, and the supraorbital artery, and the supratrochlear artery. So those are the arteries that supply the scalp from mainly the external carotid artery. Then the blood vessel for the dura mainly is coming from the it is also deriving most of its supply from the external carotid artery. So we have the anterior branch of the meningeal artery, which comes from the ethmoidal arteries, which are branches of the maxillary artery. So we also have the middle meningeal artery, which is very significant in today's lecture, as we shall see with epidural hematomas. It is and also the accessory meningeal artery, which is branches of the maxillary artery. So we also have the posterior meningeal artery, which is a terminal branch of the ascending pharyngeal artery, coming from the external carotid artery, and other meningeal branches arising from the ascending pharyngeal artery, the occipital artery, and the vertebral artery. So, so we have to remember about at least a little bit about the functional areas of the brain, the so-called Broca's areas of the brain. So just having an overview, when you look at this brain and you divide it at in the middle here where my arrow is, you have the central sulcus, and just in front of the central sulcus you have the primary motor area, and that is responsible for controlling the voluntary muscles, the motor function that we assess when we are doing our Glasgow Coma scale. And behind of the central sulcus we have the primary sensory area, which is responsible for skin sensations and is responsible for the sensations that we are testing when we are doing our neurologic assessment. In the frontal lobe is very key, because the behavioral aspects that we are testing when we are doing our GCS, movement, concentrating, when we are looking at the behaviors that we test, that we see changing in head injury, they are controlled by the frontal lobe, which involves movement, problem solving, concentrating, thinking, personality changes, and mood changes that we usually see externally. Another area that is very important is it is also located in the frontal lobe, but it is called Broca's area, and this is responsible for controlling speech. Remember, we use verbal assessment in our Glasgow Coma scale assessment. Then this is the transverse sulcus, which divides the parietal, the frontal, and the temporal lobe. So this temporal lobe also has key functionings in hearing, language, and memory, and also towards the posterior end of the temporal lobe, you can see the Wernicke's area, which is responsible for language perception, and again we have that assessment when we are doing Glasgow Coma scale. So then the brain stem, which is responsible for controlling the heart rate, the blood supply, the breathing patterns, is also going to be talked about in our today's discussion. Then the parietal lobe is mainly responsible for, it is mainly responsible for sensory functions. So we have language, perceptions, body awareness, attention, and then the occipital lobe mainly is responsible for vision, perception, mainly that. So these are the functional areas that we need to keep in our mind when we have these patients, and also in today's discussion. So we will now start head injury proper. We'll talk about the fractures, then we'll also talk about the traumatic brain injury. So we'll start with skull vault fractures. The fractures, they can be closed fractures. What it means by closed, it means that the scalp layers that we have seen, they are intact. You look at the person, the head is intact, there is no wound, and they have a fracture inside, and that fracture can be a linear fracture, as we shall see in the next slide, of the skull, and when that happens, most of the time it is managed conservatively. So we can also have open fractures. The open fracture in that case, the scalp is not intact, it is broken, like the picture which you saw on the first slide. So you can also have comminuted fractures, and when this happens, you have an open or comminuted fracture, you have to do thorough debridement, irrigation, and give prophylactic antibiotic therapy. So, and then you have to observe carefully if there are associated brain injuries that have occurred. So you can also have simple or linear fractures, as we shall see in the subsequent slide, or you can have compound fractures, depending on the number of fragments. In the subsequent slides, we shall see fragmented fractures of the brain, or of the skull. We also have ping pong fractures, which are very common in children, and this is because their skull is still soft and can bend in. So they show a local concavity in the skull without sharp edges. So usually these do not require intervention, unless if they are causing neurologic deficit, then we'll have to do intervention. So depressed, then we can also have depressed skull fractures. This is talking about the relationship of the fragments of the fractures with each other, and the depression involves inward displacement of the bone fragment. So these pictures here, they illustrate, the picture on the left illustrates a right frontal depressed skull fracture with linear and displaced fracture and the right parietal bone visible. So this fracture here, you can see a fracture line where there is my arrow. That is the undisplaced linear fracture that we are talking about. So so this picture here is illustrating a small depressed skull fracture here. You can see where my arrow is. It's showing a small depressed skull fracture in the parietal bone, and the picture. So yes, so you can see the parietal bone. You can see the reconstructions. These are reconstructions. They are 3D reconstructions of this depressed fracture that you see on this actual view. So this is the 3D reconstruction of that fracture. You can see here where there is my arrowhead, and this is the impact that it had on the dura. Also, this is a 3D reconstruction. So still we have more examples of skull vault fractures. This actual view of the CT, it shows a depressed skull. It is depressed skull fracture that required surgical elevation and dura repair. The patient also had an underlying brain contusion and presented with deceptive aphasia. So you can see the bone fragment here. It has broken off and it has been displaced inside. So we will be looking at which depressed skull fractures qualify for surgical elevation in the subsequent discussion. Again, this actual image is showing a ping pong fracture. You can see the inward concavity of these ping pong fractures. These ones that you are seeing here, they are not really fractures, they are sutures. They are not fractures. They could actually be mistaken for linear fractures, but this is a child and most of the bones have not united, so these are normal things. So the indications for surgery in depressed skull fractures, we have the absolute indications and the relative indications. And the absolute indications is that is when you have a displacement of the segment greater than the thickness of the bone itself. So if this, you can see the displacement here is really inside, is greater than the thickness of the bone. So that was an absolute indication for elevating that fracture. Also, if you can measure that displacement. If it is more than 10 millimeters, that fracture has got to be elevated surgically. Then if you have associated significant associated intracranial hematoma, you have to elevate that. If you have significant frontal or nasal sinus or nasal duct involvement, if you have gross contamination, we had a case for people who were on the ward last semester in KIU. The child was hit with a piece of wood, a dirty piece of wood. The patient came to KIU with gross contamination, and that child, the skull, the fracture had to be elevated. So if you have significant pneumocranium, pneumocranium can also increase intracranial pressure, so you'll have to elevate that fracture. Then there are relative indications for elevating fractures. If it is between 8 and 10 millimeters of the displaced fracture, you may or you may not, depending on how the patient is. So if you have a neurologic deficit clearly attributable to the compression of the underlying brain, if you have persistent cosmetic problem, especially for our sisters, you might have to elevate that fracture for purposes of cosmesis. If you have significant dural laceration, we saw a dural involvement in the first images that we saw illustrating skull fractures, you might have to elevate that fracture. Those are relative indications for elevating depressed fractures.
Hello?
Yes, doctor.
Yeah, so we take note they are actually be getting many patients with skull fracture, and the good thing, majority of them find they don't qualify for what? For surgical intervention. And I'm sure you meet some, or you could have already seen some on the ward, some patients with skull fractures.
Yes, doctor.
Yeah, but before you continue, did you give us, apart from the road traffic accident, seems I didn't see a side of what of the causes, because now that's part to explain about this contamination things we are talking about. So do you have a said about causes of traumatic brain injury?
Causes?
Yeah, seems I didn't see that right. I think when I talked about RTAs in epidemiology, but seems I didn't see the side of the causes.
We will improve that and include the causes, yes.
So what are they, apart from the road traffic accident?
So they can be falls from heights. They could be abuses, like child abuse. There could be torture victims. We also have violence from guns. We have in people who are in war zones. You have injuries from the bullets. We also have domestic violence. Those are some of the causes.
So basically having watched the assaults, isn't it? Assaults, falls, then of course, those gunshot injuries, burst injuries that can cause what? The penetrating head trauma. And also don't forget what? The sports injuries.
Yes, doctor.
If you are a soccer fan, you could have seen like in Premier League, if there's any slight collision between those players, they are always mindful about what? About like those players getting what, even a simple what, concussion. So sports injuries are also one of the causes of what, of this head injury. So you are going to put a said about the causes of what, of these injuries, the head trauma, traumatic head trauma or traumatic brain injury.
Yes,
You
doctor.
put it said in addition to epidemiology. Then you also get more data. Like we get to know at the global level, then sub-Saharan Africa, where are we? Then you come to at the national level. Because rates, most of these cases are actually most common in what? In sub-Saharan Africa. So you need to bring out also that data well. You continue.
Yes, doctor. We had said that 40% of the deaths from these injuries are occurring on the African soil. So we will include that data in the epidemiology section. So the skull base. So we have, so that is that what we had on the skull vault fractures. So we will now move to the skull base fractures. So when the patient has a fracture of the base of the skull, we will see CSF leakage. We can see CSF leaking from the nose, from the ears. That is CSF otoria. We can see CSF rhinorrhea. We can see Bartol's sign, which is the bruise just behind the ear. We can see panda eye, which is periorbital darkening, and we can see hemotympanium if we do an examination of the tympanic membrane. So yes, doctor.
What is the panda eye?
A panda eye is periorbital darkening, periorbital edema and darkening.
So it's not edema, it's periorbital what? Ecchymosis, isn't it?
Ecchymosis, yeah, periorbital.
Yes. Then for the Bartol's sign?
It is post-auricular ecchymosis also.
So you take note that animal that is what? That is like what we call what is called a panda. So its eyes they resembles what? As periorbital ecchymosis. So that's where the name originated from.
Yes, doctor.
Then we need to get to know, how we get to know that someone is having what? Like rhinorrhea, because we also take note, like, that danger tongue on the face, if anything happens, like most people want to bleed from the nose.
Yes, doctor.
So you need to know, when do you get to know that someone is having what? That rhinorrhea.
Yes, for the blood that is coming from the nose, it doesn't easily clot, or from the ear if it is having CSF mixed with it. So for us to determine that is mixed with CSF, we do what we call a halo test, and in the halo test, we put some of that, a drop of the blood on the filter paper, and then the blood will concentrate at the center, and then the CSF will form an outer ring, which looks like a halo outside of the centrally concentrated blood. So that is how we know that we are having CSF rhinorrhea, CSF.
So you get what? Two rings, isn't it?
Yes, doctor.
You get two rings. The outer one you find is pale, indicating what? Indicating CSF. Then the inner one we find is a bit like a thick or dark red, indicating what? The usual blood. But then
doctor.
we'll be having what? The outer one we find what? It is pale compared to the central ring. So you're having what? Two ring. That's why it's called what? A double halo sign for when there's what? Rhinorrhea or Tourette. So it will be what? A double halo sign.
Double halo sign.
Okay, you continue.
Yes, so we can also suspect that the person has skull base fracture when we find injuries to cranial nerves. The first cranial nerve, the ophthalmic nerve, the olfactory nerve could be injured during this fracture, and the person will present with inability to smell, also called anosmia. The optic nerve can also be involved, and the person will present with visual deficit, and also when the temporal bone is involved, the facial nerve can be involved, and the person will present with facial nerve weakness. Or if it is the eighth cranial nerve, you'll have hearing loss. So you can also have pituitary gland or stroke injury, and that can result in endocrinopathies. We know the role of the pituitary in endocrine function. So this is how you start thinking that this person could actually be having a fracture base of the skull. Air sinuses injury or mastoid air cells may result in meningitis, a feared complication in skull base fractures. And when we are suspecting actually skull base fractures, we have to give these people antibiotics. So meningitis can manifest even years after the initial event. You can have vascular injuries. You can have vascular injuries to the vessels that penetrate the skull base, and you can have arterial dissection, traumatic aneurysm formation, traumatic carotid cavernous sinus fistula formation, and cranial neuropathies that may occur because the blood supply to those parts of the brain have been compromised. So we will not discuss skull-based surgery in today's discussion. It is beyond the scope of today's discussion. Then we will turn our attention to the fractures of the face. Mainly, we are concerned with the fractures of the maxillary and frontal bones, and these fractures, they can bleed a lot, and that bleeding can actually compromise the airway. You can have the clots going into the airway, you can have the blood going into the airway, and if the person has altered consciousness, this person can actually aspirate and die from this. And it requires a significant amount of energy for you to have these fractures. So mainly you might most likely have other associated intracranial injuries. So it can affect smell, it can affect sensation, it can affect smell, it can affect sight, it can affect taste. Most common facial fractures involve the nasal, zygomatic, and the mandibular bones. So Lefort Rene described these variations in the maxillofacial fractures, but we might not always find this typical classification in our patients, but it is very common to find these patterns which were described by Lefort. So we have Lefort 1, Lefort 2, and Lefort 3. Lefort 1 is illustrated here, where you can see my arrow. It is where there is fracture of the pterygoid plates through the lateral wall of the maxillary sinus and piriform plate of the nose. So just below the opening of the nose, as you can see the red indications on this picture. Then Lefort 2 is whereby the whole of the dentition, this is Lefort 2, this is Lefort 2. So the whole of the dentition bearing portion of the maxilla and the nasal bones from the pterygoid plates to the anterior orbital rim and across the ridge of the nose. So that is Lefort 2. Then Lefort 3 is essentially where the whole of the mid face is separated from the skull base, and it is also called a floating face. So you also have other facial injuries to the orbital rim. You have dental injuries. You have seen a lot of these. You also have nasal fractures, which will also be considered in another section of maxillofacial surgery, which is not discussed in today's discussion. So we will now move on to traumatic brain injury, which people just say when you say someone has head injury, people their brain run immediately to think that someone has traumatic brain injury. Actually, when you say someone has head injury, people think it is TBI. So we are now going to discuss TBI in detail. So so the brain tissue comprises about 80% of the intracranial volume, and the dura forms the compartments within the brain tissue, and it receives 15% of the cardiac output, CSF produced by the choroid plexus daily, and it is its main job is to cushion the brain, and it drains back through the villi. Talking about traumatic brain injury, we have to always, we cannot talk about traumatic brain injury without talking about the Monro-Kelly hypothesis. And this Monro-Kelly hypothesis describes the intracranial pressure volume relationship with the cerebral perfusion pressure in the rigid cranium. The cranium is described as a rigid box, and then there are pressure volume relationships that occur in this rigid cranium. And this was described by the Monro-Kelly hypothesis. So it says that the brain, the blood, and the CSF volumes, they remain constant according to this this hypothesis of Monro-Kelly. So an increase in one component of these three components reduces the volume of the other, because the skull is rigid. So so this balance is maintained by cerebral autoregulation, which can be compromised in the setting of trauma. So there is so because of the compromising of the cerebral autoregulation, it requires us to actively manage this, because raised intracranial pressure can compromise cerebral perfusion, resulting in a vicious cycle of secondary brain injury and edema because of the failure of the sodium potassium ATPase pump that we are going to see in the subsequent slide. So these pictures here are illustrating the Monro-Kelly hypothesis. The picture on the top shows the normal components of the skull. This is the rigid box of the skull. It has CSF, it has brain, it has arterial blood, and it has venous blood. So now the picture which follows that illustrates introduction of something else, a mass, maybe a hematoma that has been introduced. So when that mass is introduced, it means the other volumes have to reduce to accommodate this hematoma. So you can see the CSF is being forced out of the skull, and also venous blood initially is being forced out of the blood because of the mass lesion in the compensation phase. So the CSF is pushed out, venous blood is pushed out, and there is no manifestation, there is no big deal, there's nothing being seen, and the patient is not having a very big problem. But then that compensation wears off, and we have decompensation with herniation syndrome, which causes brain herniation syndrome. You can see the hematoma has increased significantly in size, or the mass, whichever that is, and it is compressing the brain, the arterial supply, and the CSF and the venous blood. So when this happens, that is when you have the brain herniation syndromes that we will look at a little bit later. So so this results in increasing intracranial pressure. So the consequence of the increased intracranial pressure is that
Hello?
Yes, doctor.
Hello?
Yes.
So before the ICP goes high, what is the normal ICP?
It's about 20. It's about 20. It is here.
Sebastian.
The normal is
So we have
5 to 15. 5 to 15.
Yes, so the always what ranges. So
Yeah.
so then what is the normal amount of blood that flows to the brain? Because you need to know the normal physiology for you to appreciate where this passage is.
So it is 15% of the cardiac output.
Like, what amount of blood flows to the brain like in a minute? You're having a patient, he has gotten involved in an accident. you are aware of hypoxia. So how much blood should be flowing to the brain tissue, like in a minute? Because there's a stage when you find if it's not getting adequate blood supply, then you start getting what? Those brain cells, that's what? Dying. So you check out what? The cerebral blood flow, like how much blood flows in a brain tissue per minute, isn't it? Then so when you're having the vein arterial pressures, then you to set the sector. So find out how much amount of blood flows the brain per minute, isn't it?
Yes, doctor.
Go on.
So I was talking about the consequence of the increased intracranial pressure. Hello?
Yes. You continue.
Yes, so we said it can be from a hematoma or a contusion or brain edema itself. So so the consequence, we said it is herniation, and we are going to look at the herniation syndromes. So the features of increased intracranial pressure include a decreasing pulse rate, a headache, nausea, vomiting, decreased alertness, bradycardia, sluggish or non-reactive pupils, decelerate posturing, and increased or widening pulse pressure. So this typically manifests if it has worsened as a Cushing triad, which is a triad of bradycardia, chain stop respiration, and a widened pulse pressure. So
Hello?
yes, doctor.
How does this bradycardia comes up when there is increased ICP?
Because of the compromise of the brain stem, the cardiovascular centers in the brain stem, that is how the bradycardia comes about.
So you read about what? The relationship with bradycardia and those cardiac baroreceptors, isn't it? How they bring about what this bradycardia and what? When the ICP goes high. Then in the hypertension, why are we getting hypertension in these patients?
So we're getting hypertension because the body is trying to compensate to increase the cerebral perfusion because of the compromise. So the pressure tries to go up to overcome, to supply the brain.
Okay, that's right. You continue.
So this picture here is illustrating the herniation syndrome. This one, the first arrow, which is labeled 1, is showing the subfalcine herniation. So subfalcine is denoting to the falx cerebri here, which is the dural fold that goes inside of the cerebrum. So the cingulate gyrus here, as this arrow indicates, is herniating under the falx cerebri. You can see the midline shift that is evident, and the arrow on number 3, it shows ankle herniation, which is herniation of the temporal lobe over the tentorium cerebelli, where it can compress the third cranial nerve. And we will see a discussion on what happens when the third cranial nerve is depressed. So then number 4 is the central herniation, which presents with the classical Cushing triad, and number 5 is the tonsillar herniation, which results in brainstem compromise, also adding on the Cushing triad. So, and when this happens, the patient is said to be coning, and brainstem death could follow immediately if there is no intervention which is done. So this slide is talking about the cerebral perfusion pressure, which is also talking about the pathophysiology, but we will also talk about pathophysiology in front. So the cerebral perfusion pressure is calculated as the mean arterial pressure minus intracranial pressure, and CPP, the normal range. Doctor was mentioning that we have to be aware of the normal ranges. So normally we have 75 to 105 millimeters of mercury, and MAP normally is 90 to 110 millimeters of mercury, and ICP is 5 to 15 millimeters of mercury. So if you have an increase in the ICP, if you have an increase in ICP, it means the CPP is going to reduce, because they have a converse relationship. So to be able to calculate the MAP, there are two ways. I think there are also other ways. You can get 2/3 of the diastolic pressure plus 1/3 of the systolic pressure, or you get the diastolic pressure plus 1/3 of the pulse pressure. So so if the intracranial pressure is exceeding if it is exceeding 20 millimeters of mercury, it means it is going to cause the mass effects that we have described in the previous slide, and it requires urgent intervention. However, we have to note that lowering the blood pressure too fast, which might happen when you give someone mannitol, can also decrease the cerebral perfusion pressure, creating another problem altogether. So the classification of head injury. So what I did not mention about this is that when you have increased intracranial pressure and a compromised blood flow to the brain, a compromised cerebral perfusion, you get hypoxia. So when you get hypoxia, you are not having enough oxygen being delivered to the brain cells. So if you're not having enough oxygen being delivered to the brain cells, the brain cells will switch to anaerobic respiration, and the anaerobic respiration will not make enough ATP. And if you're not making enough ATP, we saw the sodium potassium ATPase pump, it is going to fail. So when the sodium potassium ATPase pump fails, it means instead of the sodium being pumped outside of the cell membrane, it is going to just go inside of the cell of the brain cell. Now, when sodium goes inside of the brain cell, water always follows the sodium. So when water follows the sodium and it enters the brain cell, it starts to swell up, and you have edema, and you are again increasing intracranial pressure and worsening the problem. Also, this membrane instability created by the failure of the pump mechanism and the hypoxia causes influx of calcium ions, and these calcium ions they alter the excitatory mechanism of the brain cells, and you end up with these convulsions and the other manifestations that we see in brain injury. So the concept of cerebral perfusion pressure and intracranial pressure is very important, and we have to manage it actively if we are to save these patients.
John, hello?
Yes, doctor.
Hello?
Yes.
So you need to, in addition to that Cushing's triad, you need to know other terms of what of increased ICP. So I don't know if you have that slide.
Yes, I mentioned other features like headache, nausea, vomiting, decreasing alertness, non-reactive or sluggish pupils, decelerate posturing, and widening pulse pressure.
So you take note, this vomiting is not the usual what? vomiting. It is what?
It is projectile.
It is the projectile vomiting. And in our setting where we're not able to measure the ITP in most places, that means we shall base on these presentations to get to know the patient's ICP is what has gotten raised. So
Yes,
basically, where we are limited with investigations, now here we have to rely more on what? On the clinical presentation of what? Of the patient to know what's going on. So you should know them. You continue.
So the classification of head injury, we have classification according to severity, and this is the preferred classification, and the motor response is the best predictor of neurologic outcome. So we will look at Glasgow Coma Scale in the subsequent slide, but it has a shortfall in that it can be misleading. You have to be clear with your history. I have to connect my charger. So you have to be clear with your history. Yes, you have to be clear with your history to rule out whether the person is under the influence of alcohol or if they have taken other drugs that could be altering their level of consciousness. Then there is the general classification, which could be talking about open or penetrating injuries. The doctor talked about the penetrating injuries caused by the ballistics and the bullets, or it could be closed injury, where it is caused mainly by blunt trauma. Then it could be according to mode of injury, which is etiologic classification. It could also, there is also pathology classification. So talking about Glasgow Coma Scale, we look at 3 parameters and we look at the best of those that we get. Yes, doctor.
Yes, first go back. So you take note also, depending whether it is on the whether someone has got an initial impact or is suffering from the consequences of what? Of the initial impact. And that's what?
Primary.
Being the primary and what? And secondary TBI.
Yes, doctor.
Okay, you continue.
So this is talking about the Glasgow Coma Scale, which talks about 3 parameters: the verbal, eye, and motor parameters. So in the eye, on the eye assessment, we look at 4 parameters, and we have 5 for verbal and 6 for motor. So the highest score that a person gets is the best score that we give the person. So if the other eye is edematous and we cannot assess it, but the other eye is open, we score that eye which is opening, the best one. So so the person who opens eyes spontaneously gets a 4. If they open to speech, they get a 3. If they open in response to pain, they get a 2, and they get a 1 if they don't have any eye opening observed. For best verbal, we have the one who is fully oriented gets a 5. The one who is confused gets a 4. The one who is speaking inappropriate words gets a 3, and the one who is speaking incomprehensible words, incomprehensible sounds, gets a 2, and 1 for none. Then best motor, 6 is obeys command, 5 localizes pain, 4 withdraws from the pain, 3 flexes in response to pain, 2 extends to pain, and 1 has no motor response. So this helps us to classify our head injury. So for those ones who are having 15 with no history of loss of consciousness, they are classified as minor head injury. Those ones who have
Hello? Yep, John. Hello?
Yeah, yes.
Can you first go back? So I was saying what this adult and pediatrics, this is, so if you're having a 5 months old, 5 months old baby, how are you going to score his verbal? Well, I'm saying you're saying this way. You are calling it adult and what? And pediatrics GCS.
No, we have the
Say someone that.
we have the pediatric score here.
So you need to change that heading, isn't it?
Okay.
So
okay.
the first one is for what? Go back.
It's for adults.
So that one is for adults. So if you say adult and pediatric GCS, so with this one, like if you're having a 5 months old baby, you'll not be able to assess that verbal response. You'll not be able to tell the kid is what, is he confused or is having what, inappropriate words. So this is what? For the adult, isn't it?
Yes,
So
doctor.
for the children, we have what we call the modified Gascoma scale. Go on.
So for the children, we have the modification of the adult. So for children who are under 1 year, children who are 1 to 4 years, and those ones who are a bit older, above 4 years. The ones who are above 4 years, they are tending more towards the adult form. So for the infant who is under 1 years, again we assess eyes, verbal, and motor. For the eyes, the infant opens the eyes spontaneously. They have a 4. If they open in response to voice, they have a 3. If they open in response to pain, they have a 2. And if they have no response, they have a 1. So for the verbal, if they are playing about, they are bubbling, they are making bubbling sounds, they score a 5. So if they are irritable and they don't want to see you, but they can be consoled, they score a 4. And if they cry persistently in response to pain and you cannot console them, they get if the mother cannot even console them, they get a 3. And if they just let out moans to pain, they get a 2. And if they don't get any response, they get a 1. Then for motor, if they have normal spontaneous movements, their limbs are always playing, they have a 6. If they withdraw from touch, they have a 5. If they withdraw to pain, they have a 4. If they have decorticate flexion, they have a 3. And if they have decelerate extension, they have a 2. And none. If they have none of these, they have a 1. So for children who are 1 to 4 years, the parameters on the eye, they are the same to those ones who are below 1 year, and even those ones who are older. The difference is on the verbal parameters, whereby they get a 6 if they are oriented, they speak, they try to speak to you, they interact, and they are social. They get a 5 if they are confused, they are giving a confused speech, disoriented, but they are consolable. They get so that is for a 4. For a 3, they get a 3 if they are giving inappropriate words and they are inconsolable, and they get a 2 if they are using incomprehensible words and they are agitated, and they get a 1 if they have no response. Then for motor, the best is 6 if they have normal spontaneous movement, and then they get a 5 if they localize pain, a 4 if they withdraw to pain, a 3 if they have decorticate flexion, and a 2 for decelerate extension, and 1 for no response. The children who are above 4 years, they are usually essentially assessed the same way how we assess the adults. So talking about the types of the head injury that we have talked about, the minor head injury, mild, moderate, and severe, we are now focusing on the mild and minor head injuries. So the patients who come to us and we assess them and think that they have minor or mild head injuries, after ruling out C-spine injury, we can discharge them home. But we have to follow a criteria, and in this case we follow the UK National Institute for Health and Care Excellence discharge criteria for mild and minor head injury. So for a person who scored GCS 15 out of 15 and they didn't have any focal deficits, they qualify for discharge. If they have a normal brain CT, if it was indicated, we are going to see the indications for brain CT scan, and it is normal and they are okay, we can discharge them. If they are not under the influence of alcohol or drugs, if they are accompanied by a responsible adult, and if we give them written and verbal head injury advice. So this written and verbal head injury advice tells them to come back for medical attention if they get these symptoms. If they get persistent or worsening headache despite analgesia, if they get persistent vomiting, our supervisor said it has to be projectile vomiting, indicating increased intracranial pressure. If they have drowsiness, if they have visual disturbances, if they have limb weakness or numbness of any of the limbs. So if they get any of these symptoms, they have to come back to the hospital for review. And we are supposed to write this advice on the discharge form when we are sending these patients home. Patients who do not meet the discharge criteria should be sent for CT scan, and again, we follow the NICE guideline. So the NICE guideline indicates that we should do CT scan within 1 hour if the patient has had a GCS of less than 13 at any point. If the patient has a GCS of less than 15 at 2 hours, or if the patient has any focal neurological deficit, or if we suspect open or depressed or basal skull fracture. We saw how we are able to tell that the person has basal skull fracture by clinical suspicion. If the person has more than one episode of vomiting, or if they have a post-traumatic seizure, these people must go for CT scan within 1 hour. So within 8 hours, if we might delay a bit to do the CT scan and maybe do it later, maybe 8 hours later. If you have someone of 65 years, more than 65 years, and they don't have the above criteria, if they have coagulopathy, or if they are taking anticoagulant medications or antiplatelet medications, if they are on aspirin, warfarin, or rivaroxaban, if they have been involved in a dangerous mechanism of injury, such as a fall from a height or a road traffic accident, or if they present with retrograde amnesia for more than 30 minutes, they cannot remember the events before the accident. These people, we have to take them for CT scan.
Hello?
Yes, doctor.
Clarify more about the dangerous mechanism of injury in relation to road traffic accident.
So if we have high speed, if we have in the history, they tell us that they were vehicles moving at high speed, and then they knocked each other, and this person is how they got their RTA. It means we have to do a CT scan for them.
Tony. Tony.
These are colleagues from the other sites, but they are also our classmates.
Yes, it is fine.
Yeah.
Dr. Tony. Okay, Sebastian. Those people there, all they have. Sebastian. At time the disadvantage of with Zoom. Abubakar.
Yes, bro.
They just make an injury in relation to RTA, what is considered to be dangerous mechanism.
I think it is debate on how the speed of that accident and is the severity. For example, if the accident was the high speed, you can suspect the acceleration and the acceleration, or it can damage for the brain.
So you are going to read about the Canadian city head rule. Hello?
Okay.
Hello?
Yes,
Yes,
bro.
doctor, we are hearing.
Yes, so you are going to read about what we call the Canadian city head rule, then you read about what is considered for dangerous mechanisms of injury. So basically, when you find someone is in a vehicle, is an occupant, and as is in motion, is ejected out from that vehicle, or if he's a pedestrian and then is struck by a vehicle. Then you read about a fall from a height. The feet that is what considered that fall, that if you measure what is considered to be fall under the dangerous mechanism of what of injury, where you put for what a fall from height. So read about the Canadian city head rule, then read about the inclusion criteria and the exclusion criteria of the Canadian city head rule. You have heard?
Yes, we have heard.
Okay, you continue.
So that is it for the minor and mild. So for the moderate and severe head injury, management always follows the ATLS guideline of primary and secondary survey. But we have to take the history and know about the pre-injury state of this patient, whether the person was having convulsions before the injury, maybe they were epileptic, if they were intoxicated with alcohol, if they had chest pain prior to the accident, before we start attributing whatever we are seeing to the accident or to the trauma. Mechanisms and energy involved in the injury, the speed of the vehicle's height fallen, like how our supervisor has mentioned, there is a specific height that we consider to be a dangerous mechanism. If there was direct impact on the head and time taken from getting the person from, especially for car accidents, from the car to the hospital. If they have a history of convulsions, bleeding from the nose, eyes, from the nose, ears, and throat, if they have history of loss of consciousness, if there is a lucid interval, which is very important for extradural hematomas, and if there is a decreased GCS, and if there is if there was pulsus paradoxicus. If there is a headache, nausea, and vomiting, we have to ask all of these histories. Some of the histories we can ask from. Sometimes the person is brought in by a medic or a paramedic, where people have paramedics in their settings. They are able to tell you that the GCS of this person was this, and then it has decreased. Check the medication history, especially anticoagulants and antiplatelets, and all the other past medical histories. You may want to know if the person maybe has diabetes. They could be hypoglycemic, the last meal that they had, and so on. So examining the patient, you follow ABCDE.
Before that, hello, John.
Yes.
So you should be having goals managing this patient, isn't it?
I lost you.
The goals. So what are the goals that will be after? Like you should be having goals, isn't that you follow as you are going to manage these patients? What are the main goals?
So I think the goal is to prevent secondary brain injury. That's the main goal, and identify immediate life-threatening conditions that may be in this patient. So I think those are the main goals.
Mm-hmm. So what is the first?
To identify immediate life-threatening injuries.
So the first goal should be what? Like you identify and you treat those immediate life-threatening injuries. So that's why you are starting with ATLS, isn't it?
Yes, doctor.
Then the second goal should prevent that secondary head injury that we talked about. Then after that, you treat other injuries. Okay, go on. So basically, that management falls under those three goals: identifying or preventing and treating the immediate life-threatening injuries, then prevention of that secondary head injury, then also that's still treating other injuries. Because remember, some of these patients also they can be polytrauma cases. They can have injuries to the brain, but they can also have injuries to the chest, the abdomen. So in some cases, they can be polytrauma patients. You go on.
Yes, so we assess the pupils. We are supposed to measure the size in millimeters, assess the reactivity of the pupils, and report whether they are reactive or whether the response is sluggish or whether there is no reaction at all. So when you find a dilated pupils, it means there is compression of the third cranial nerve, which could be from ankle herniation, and that blocks the parasympathetic innervation to the iris, to the pupils, and then that allows an opposed action of the sympathetic stimulation, leading to a dilated pupil. So we have already said that the best response should be recorded, and we also assess the vitals, the blood pressure, temperature, respiratory rate, and pulse rate. And we look for any focal neurologic deficits. We assess for power, tone, sensation, coordination, and reflexes for all the 4 limbs. So in the secondary survey is done when the patient has stabilized or is stabilizing, and we do this to identify the issues that are not immediate life-threatening. In this case, we do a full head, eye, ear, nose, throat exam. We examine the neck all the way to the toe by paying attention to each of the systems. So about the head, We look at the scalp and the oral cavity. We look at the teeth, the jaw alignment. We saw the fractures, the Le fractures, and the dental injuries that are common in head injury. We do a cranial nerve exam. We look for facial fractures, CSF blood from the ear or nose, looking for the double ring sign in the halo in ruling out CSF rhinorrhea or CSF otorrhea. For the neck, we are looking for midline tenderness. We are looking for step-offs. You are palpating to look for step-offs, which could indicate fractures of the cervical spine, or we are looking for deformities. For the chest, we are looking at for expansion. If there is equal chest expansion, you are looking for breath sounds. If you're having equal air entry, you are palpating for crepitus, which could indicate a pneumothorax. You are looking for tenderness, maybe due to rib fractures. You're looking for bruising or any deformities that you can see. For the abdomen and rectum, you're looking for tenderness, you're looking for bruising. Some bruising patterns could indicate serious abdominal injuries. You're looking for blood in the rectum. You're looking for the tone in the rectum. If you are losing tone in the rectum, that could mean that you have spinal cord injury. You're looking for position of the prostate. For the pelvis and genitals, you're looking at the stability of the pelvic bones. You're looking at the urethral meatus to see if there is blood at the meatus, indicating injury to the urinary system. Vaginal bleeding, actually a vaginal examination should be part of the secondary survey when you have patients. You're looking for scrotal bruise. You're looking for priapism, which is a strong predictor of spinal cord injury. Then you do a log roll. And look at the back, looking for bruises or swellings, looking for crepitus and step-offs, which could indicate injury to the spine. Then the limbs are examined. You look at the vascular, you look at the pulses, as may be appropriate, the popliteal pulses, the dorsalis pedis, the posterior tibial pulses, to see the status of the vessels, because if these vessels are not, if the vascular status is not okay, the limbs will be compromised. You look at the musculoskeletal status, as we saw in the discussion of musculoskeletal injuries, if you have fractures and so on. So this is in the secondary survey. So irrespective of whether you are having in your mind that this patient is having a moderate head injury or severe head injury, you have to do this full assessment for your patient, because if you miss some of these things, they can actually complicate the picture of the management. So the investigations, imaging, CT scan or MRI, we have seen the indications for CT scan, and you have an assignment of looking at the Canadian CT head rule. You do carotid angiography to look at the status of the blood vessels. You do X-rays, trauma X-ray series. You might have to do not just an individual, like saying just go for chest X-ray and then you just do that. No, we have what we call the trauma X-ray series. You might, depending on what you're finding, you might have to do a chest X-ray, you might have to do a pelvic X-ray, you might have to order for an abdominal ultrasound, you might want to X-ray some of the limbs, and so on. So for the blood, you want to send for blood urea and electrolytes. You want to send for electrolytes, random blood sugar, complete blood count, group and cross match, liver function test, and blood gases. So for coming back to our head injured patient, the management of the patient who has moderate to severe head injury is two-pronged approach, and we are looking at primary traumatic brain injury, and we are also looking at secondary brain injury. So for primary brain injury is the one that comes from the initial impact on the brain and the vascular components of the head, and that can lead to lacerations of the brain and its coverings, contusions of the brain, hematomas, or ischemia. So so this primary impact can have these hematomas, lacerations. They can have a mass effect, and this one can be removed if you are in a center which has the capacity of doing these evacuations. You can manage you have this managing of the primary head injury by evacuating the clots. So or maybe if you have the primary impact on the skull bone fractures leading to focal defects that are attributable to the fracture itself, it can be managed by fracture elevation for the displaced or depressed fractures, and we have already discussed the indications for which fractures need to be elevated. So apart from those, in our resource limited settings, you may not have much to do, but you have the leverage of being able to prevent secondary brain injury. So now, focusing on the secondary brain injury, this occurs because of decreased oxygen delivery to the brain, and this in turn sets off a cascade of events that I had already discussed in the previous section, leading to more damage than the initial injury. So maybe again, because of its importance, we can recap it. There's an alteration in cerebral blood vessel autoregulation, which is further worsened by hypotension, hypoxemia, and then again that compromises the blood flow to the cerebrum. So because of that reduced oxygen supply to the brain, you have the inflammatory cascade. You remember the inflammatory response to trauma. So you have the activation of the inflammatory pro-inflammatory cytokines, and you also have anaerobic respiration. And we have already talked about the effect of ATP and the failure of the ATPase and the dysregulation of the ions, which leads to the vicious cycle of head injury that we see. So when this is not managed, we will have cell death occurring and we lose the person. So we have to avoid, so we can prevent this from happening by avoiding hypoperfusion. We have already talked about the cerebral perfusion pressure, the Monro-Kelly doctrine, which we are not going to repeat at this point. We have to avoid hypoxia and increased tissue oxygen consumption. How do you avoid increased oxygen consumption? For example, if your patient is restless, agitated, and maybe there is a history of convulsion, or even before the convulsions occur, you have to give anticonvulsants. We have phenytoin or phenobab, depending on what is available, but phenobab is preferred in children. So we said we want to avoid increased tissue consumption. We want to avoid oxygen consumption of tissues. We want to avoid hypoxia, and we want to also avoid hypercapnia. So these are some of the metabolic derangements that we are also talking about to be avoided. We said there are 3 things to be avoided. So you have to avoid hypercapnia, hypocapnia, acidosis. You want the pH to range between 7.35 to 7.45. You want to avoid hyponatremia. You want to avoid hyperglycemia or hypoglycemia. We saw in the metabolic response to trauma that you have hyperglycemia coming in, but if you have a patient with head injury and then they have hypoglycemia, this is something that you could actually correct in a single shot and see a miracle happening. So you want to avoid hypoosmolarity, which can cause secondary brain injury by disrupting metabolism. So, maintaining the partial pressure of carbon dioxide between 35 and 40 to avoid cerebral hyperemia or excessive vasoconstriction and induction of cerebral ischemia. So how do you do this? As you prepare to transfer the patient, it is a short-term intervention. As you prepare to have definitive intervention, as you prepare to go and evacuate that clot, you could hyperventilate the patient because this hyperventilation increases the carbon dioxide concentration, and the carbon dioxide causes vasodilatation, and that could help a little bit as a temporary measure as you are transferring the patient to operation to have a definitive measure. But it is not recommended to use for a long time as it is counterproductive. So the major interventions to prevent the three things that I've talked about, we have to do careful volume resuscitation because you don't want to over resuscitate or to under resuscitate. You have to be, you don't want to give too much fluids or too much. You want to have careful fluid resuscitation. You have to give oxygen to the patient. You have to elevate the head of the bed by 30 to 45 degrees to promote venous drainage. You want to ensure that you have normoglycemia. We said we want to avoid hypoglycemia. So we want to maintain, you have to do your RBS and make sure that the blood glucose is between 4.5 and 10 millimoles per liter. You want to maintain the temperature between 36 to 35, because if you have hypothermia, you're going to have the dreaded that dreaded it is the triad of what of acidosis, hypothermia, and coagulopathy. So you want to avoid hypothermia. So you also want to avoid a high temperature, as that could affect the metabolism and consumption of oxygen. Sedation, if your patient is having severe brain injury, you want to intubate them, have them in ICU, sedate them and paralyze them to make sure that they are not having increased oxygen consumption and further damage. So you want to treat fevers if they have a fever. You want to prevent and treat seizures with phenytoin or phenobarbital. Osmotic diuresis with mannitol. Yes, we commonly use mannitol to do osmotic diuresis to reduce on the edema of the brain. But we have to be very careful, because if the systolic blood pressure is below 100 and you add mannitol, we already mentioned that that mannitol is going to bring down your blood pressure and you're going to have another problem. So the alternative is using hypertonic saline, which reduces intracranial pressure without putting the patient at a risk of hypotension. And like I already said, in multiply injured hypotensive patients whom we have said the systolic blood pressure is less than 100, you want to avoid mannitol. So in summary, to reduce intracranial pressure, the mnemonic is HIVED, which is hyperventilation, intubation with sedation or paralysis, ventriculostomy or external ventricular drainage, if it is indicated, and elevating the head of the bed and osmotic diuresis. So that is how we manage.
Hello?
Yes, doctor.
Yes, first go back. So do you have to give patient patients of head injury, this centering about those anticonvulsants or TBI.
No, if we are saying we want to prevent secondary brain injury, if we have features of increased intracranial pressure, we think that these patients could actually get seizures, traumatic seizures. So we give them prophylactic anticonvulsants, or if we have a history of convulsion which has been recorded, actually, we can give the anticonvulsants.
Sebastian? Where is Sebastian?
He's not in the meeting.
Abubakar?
Yes, bro.
When are you going to consider giving these anticonvulsants?
Okay. The reason we are giving anticonvulsant is to prevent convulsion and this seizure. So if the patient has the severe head injury and we are suspecting that the patient can develop to the convulsion, we can give. So it's depending on the TCS of the patient.
Tony?
Basically, according to me, you would give anticonvulsant for those with GCS less than 9.
So, if we are going to read about what we call the high risk criteria of post-traumatic seizures, those patients with TBI who are always having high risk of getting these seizures following these head injuries. So those patients with those risk factors who are at high risk, who should get those anticonvulsants for prophylaxis. So not every patient should get them. So you are going to read about those patients that fall under the high risk criteria of post-traumatic seizures. You are hearing?
Yes,
Yes, bro.
Yes, please.
Yes.
And you should also get to know how do we classify these seizures after head injury.
You can classify as immediate seizure and early and late. So I think immediate it can begin in immediately when the patient got the impact of the injury, and it can go up to 24 hours. Then early, it can go for after 24 hours up to 1 week. After 1 week, it will be late post-traumatic seizure.
Yes, so after 7 days, those are late, isn't it? Then below 7 days or just a week, they are post-traumatic seizures. So John.
Yes, doctor.
Yes, for how long will you want to give these patients those anticonvulsants?
The patient would get anticonvulsants for 2 weeks.
So they are supposed to get them for 1 week, isn't it? But then there are exceptions. Hello?
Yes, doctor, we are hearing.
Yes, so there are exceptions when you have to go beyond 1 week. So there are 4 categories of patients who should go on to receive those anticonvulsants for what? For more than 1 week. So you are going to find out what are those 4 categories of what? Of patients that are supposed to receive what? The anticonvulsants for more than 1 week.
Yes, no.
Okay, you continue.
Okay. So now we have been talking generally. So now we will focus on
John, can I
specific.
ask one question before?
Yes, please.
So if I don't have hypertonic saline, can I use isotonic crystalloid? And some people, they say the patient can develop brain edema and these things. And also another one, if the blood pressure is low, like or the normal range, and the patient has a severe head injury, can I use the mannitol?
So I had commented on blood pressure. If you have a systolic blood pressure of less than 100, and for younger people less than 65, less than 100 of systolic blood pressure, and for older people who are maybe hypertensive and above 65 and their systolic blood pressure is above 115, you don't want to give mannitol, because if you give the mannitol, it will bring down that blood pressure and it will cause hypoperfusion to the brain, and hypoxia and cell death, and the vicious cycle, and the patient will actually worsen. So do not give mannitol in that category of patient. And we are saying the best alternative would be hypertonic saline, which can be 5% or 3%. It is going to have the advantage of reducing intracranial pressure, but also improving the volume status by pulling water into the blood vessel and improving the blood pressure of this patient. So I think that answers your question.
And
Yes.
I
and you also take note. You also take note hypertonic saline overall is more effective than mannitol in management of what? Of ICP. But as a must, if someone is hypertensive, you don't have to use what? Mannitol. And I'm sure you could have also seen people in A&E in different hospitals. Every patient of head injury, you find mannitol running. So you are going to read about indications of mannitol also when someone should get mannitol. Not all patients should what? Should receive mannitol. You haven't seen people getting mannitol every time they reach A&E.
We have seen that.
Yes, of course.
So that one is wrong. So not every patient of head injury should also what? Get mannitol, but you'll be seeing every time someone reaches A&E, the first thing is to what? Put mannitol. So read about the indications of what? Of mannitol, when to use it. You continue.
Yes. So so those were generalities. So now we are paying specific attention to specific surgical pathologies that occur when we have head injured patients. So this picture is illustrating the different scenarios that we get when we have head injured patient. We have the first one on the upper left corner here is showing we have a patient with essentially a normal CT scan, and that one is usually seen in patients who have diffuse axonal injury. Immediately below that, we have the typical view of the convex appearance of the epidural hematoma, which does not go beyond suture lines and is usually located in the frontal parietal and temporal, the frontal parietal and temporal areas. And the evident midline shift is seen if you follow my arrow here, and the ventricles have been compressed. In the middle, on top here, it is showing traumatic subarachnoid hemorrhage. If you can see my arrow, this whitening that you can see here is a subarachnoid hemorrhage on CT scan, and just below it is the subdural hematoma. A subdural hematoma takes on a concave shape, following the shape of the brain, with also showing evident midline shift that you can see here. The picture on the upper right of this illustration is showing brain contusions. These white lesions that you can see in the brain, they are brain contusions. We will discuss those a little bit in detail in the subsequent discussions. And then the picture on the lower right corner is showing some linear skull fracture here. If you can look at my arrow, it is demonstrating a linear skull fracture, which we have already discussed in the previous discussion. So we look at each individual of those pathologies, the bleeding pathologies. We start with the extradural hematoma, also called the epidural hematoma. So the epidural hematoma is a neurosurgical emergence requiring immediate surgical intervention, and it is typically caused by trauma to the temporal bone and trauma to the squamous part of the temporal bone at around the pterion, because it is very thin, and when that place gets injured, the medial meningeal artery or vein, it could be the anterior branch or the posterior branch, gets injured, and then blood starts accumulating in between, just above the dura, in between the periosteal layer and the other layer of the dura. So so the accumulation of that blood is the one which produces the picture that we see typical in CT scan, and also it keeps expanding and compressing on the brain, and it cannot spread over the surface of the brain. So that is why it easily causes the mass effect on the brain. So it can also result from injury of arteriovenous fistulas or venous sinuses or aneurysm rupture. It can also occur if you have a patient who is on anticoagulation and they get a minor injury, they can actually have an epidural hematoma. So that is what has been held for a very long time, and it still stands true now. But what is increasingly being recognized is that people get bleeding from fracture edges of the skull, and this bleeding from the fracture edges actually causes the accumulation of the hematoma, of epidural hematoma. So it is not just the rupture of the meningeal artery or vein. A lot of the patients recently are being seen to be bleeding from the fracture edges of this part of the bone that we have talked about. So blood accumulates in the potential space between the dura and the inner table of the skull, and typically this is seen in the temporal parietal region, like you saw on the previous image of the CT scan, and I also show that in the subsequent slides. So classically, it presents with a lucid interval followed by a rapid deterioration as the hematoma expands in 1/3 of the cases. Yes, the lucid interval is only seen in 1/3 of the cases, but it is very important as it illustrates the concept of compensation that we talked about when we were talking about the Monroe-Kelly doctrine and the rigid skull box. So it is important to look out for the lucid interval. The patient initially, they get the impact, and then they lose consciousness, and then they regain their consciousness, and then after that they deteriorate very fast, and this is what is called talk and die in head injury patients. So it highlights the urgency of avoidable secondary brain injury that we can always be able to prevent. So this patient presents with contralateral hemiparesis, ipsilateral pupil dilatation. We saw why the pupil dilates, because of compression of the third cranial nerve with unopposed with compression of the parasympathetic, leaving you with unopposed sympathetic effect on the pupils. So you have ipsilateral pupil dilatation. The reason why you have contralateral hemiparesis is because this mass effect is affecting the white matter components, those descending and ascending tracts, and that is why you are having the hemiparesis or paralysis on the opposite side. And this mass effect, if it goes on increasing, you have the herniating syndromes that we discussed earlier on with the cardinal Cushing triad that we saw. So this is the typical appearance of the epidural hematoma, appearing as a hyperdense biconvex lesion that does not extend beyond the sutures on the CT scan. And sometimes within this hyperdense lesion in here, if you can see my arrow, sometimes you can have a hypodense area within that hyperdense area. And now when you have that in the acute trauma setting, it means that there is actually active bleeding that is going on, and that one is hyperacute epidural hematoma that you have, and this is described as a swirl sign, and it signifies hyperacute epidural hematoma. So you may do an X-ray which might show you fracture of the temporal bone. So this picture, I have already shown you the epidural hematoma with evident midline shifting, and there is also significant brain edema because you are not able to see the sulci and the gyri in this picture. So the picture on the right is talking about a subdural hematoma, which is not going to be discussed at this moment. We'll discuss it in the subsequent slides. So management, surgical evacuation is indicated, and it is indicated in which circumstances. So if you have a midline shift of more than 5 millimeters, you have to measure these midline shifts on your CT scans that you have in the ward. If it is more than 5 millimeters, that patient is supposed to have surgical evacuation. If you have more than 15 millimeters of hematoma thickness, they usually indicate these thicknesses on the CT scan. You have to send this patient for evacuation or do the evacuation if you can do it in your setting. If you have a hematoma volume of more than 30 mils, regardless of GCS, if you have a GCS of less than 9 with focal neurologic deficit, such as anoscoria, if you have features of increased intracranial pressure, like vomiting, like projectile vomiting that we have talked about. So in this procedure, it is actually an emergency life-saving procedure. We are supposed to learn it the way how we learn scissors during internship, but we have not had that opportunity largely. We hope to get that opportunity during the training. So the principle is meticulous asepsis, and because you don't want to have any infection inside that brain. You have seen Dr. Sura and Alfred using Stavlone, then they use iodine, then they use alcohol. They are really trying to make sure that the place is as aseptic as it can be. So the principle is meticulous asepsis and hemostasis. You don't want to have any bleeding. You don't want to have any bleeding occurring. You have done your operation. You don't want to have any oozing coming into your area of operation. So a 5 centimeter vertical incision in a parietal region is made above the zygoma, and the galea is incised. The skull is opened using perforator and a bar, and the meninges are not opened. So black currant jelly clot is evacuated, and bleeding vessels are cauterized using bipolar cautery or Surgicel. There is a substance called Surgicel that you can actually apply to the bleeding edges of the fracture or bleeding edges of your bowel or vessels that you have at the surgical site. So dural hitch stitches are placed, and your patient, you can close the wound, and your patient is good to go. Postoperative, you give antibiotics, anticonvulsants, analgesia to your patient, and you're worried about complications, which could be post-traumatic epilepsy or amnesia or meningitis or the other complications that you can also have surgical site infections and so on. So that is the main. Yes, doctor.
Yeah, so what is the procedure that you are describing here?
It is a craniectomy.
Craniotomy.
It is craniotomy, doctor. It is craniotomy.
And you also have to know, like in a setting where you where you don't have ICU, then you can do what? You can do a barhole. It can be life-saving for these patients where you are not able to be able to do a craniotomy. So you can do a barhole for epigiohematomas. Okay, you continue.
So
how can I know the hematoma thickness? How is it the way we can measure?
You have heard the question, John?
yes, I have heard the question, and I had actually commented about it. Usually when you have that CT scan picture, they have measured, they have actually put the thickness. If they have not put it, you can draw on a piece of paper those millimeters. You can divide and put those millimeters, and then you approximate on the lesion, so you will be able to see the size of the lesion or the thickness of the lesion. If it is more than 15 millimeters, it is supposed to be evacuated.
So normally when they're doing those CT scans, like those radiologists, like the way they do even for these visual scans, commenting about maybe the size of swings and so on. So even here, the radiologist will give you a thickness and the volume of those different hematomas. You continue.
So the medical or conservative management is by serial neurological examination to see how your patient is improving, and if you are able to do serial CT scans, you can do serial CT scans, and you give medical treatment. So that was about the epidural hematoma. So now we want to focus on the subdural hematoma. So the subdural hematoma occurs when blood collects between the arachnoid and the inner dural layers, and it is between the arachnoid and the inner dural layers. So remember, the other one was above the dura. Now this one is below the dura, between the dura and the arachnoid. We saw those layers at the beginning of this presentation. So it can be classified as acute subdural hematoma, which is less than 2 weeks, or it can be subacute between 24 hours to 2 weeks, or it can be chronic, which is older than 2 weeks. So there are two broad contexts of the etiology for subdural hematoma. The first one is where the victim gets a high energy injury mechanism, which results in rupture of the cortical surface vessels, which with significant associated primary brain injury. So that results in an expanding hematoma with rapid deterioration, and it requires prompt surgical evacuation, typically by craniotomy or craniectomy. So this image here is illustrating the classical appearance of the subdural hematoma. You can see it going over the brain surface. You can again see it here in the CT scan image. If you can see the arrow on the image here, where my pointer is, this is the typical appearance of the subdural hematoma, which we had alluded to.
Hello?
Yes, doctor.
Then you should be able to tell the difference using the CT scan between the acute and what? The subacute and the chronic subdural hematoma from what? From the CT scan. How do you tell the difference?
Yes. Oh, so the acute one is a hyperdense lesion. As we can see, this one here, this is bilateral actually. This is hyperdense. You can see, and also this one is hyperdense. So that one is acute. But the chronic one, the blood gets so initially there is fresh bleeding which forms the clot, but after the initial bleeding, the clot within the subdural space begins to do what? To break down. So when it starts to break down, the osmolarity the osmolarity of these breakdowns causes water like fluid to come from the brain into the clot. So that means that the clot is going to become less concentrated, and it appears as hypodense. It may be isodense or hypodense. So in I think I have images in this presentation. In chronic subdural, you have a hypodense appearance of this lesion actually, and in subacute you might have an isodense appearance of this image.
Okay, you continue.
So that was the first group of the image, and this one, they are bilateral, meaning maybe there was an impact on one side, and then the brain shook in that skull, and then it injured the other side also. The so-called coup and counter coup type of subdural hematoma. So the second group of patients with subdurals are older and often anticoagulated patients, or they are people who are chronic alcoholics. So these ones, they will have there will be a history of a lower energy injury. Maybe they slid and fell when they were walking, maybe from a bar, or maybe just walking around in the compound. They something trivial. So they have venous bleeding around the brain, and they get the subdural. So it can present acutely or chronically depending on the volume of bleeding, and the chronic cases may appear later due to osmotic expansion or remain asymptomatic only to develop into acute or chronic hematomas that we have already discussed a little bit about. So large bleeds, they can cause significant midline shift. As you can see in this CT image, there is this big bleed here of the subdural, and it is causing midline shifting, if you can follow my arrow. So significant midline shift or deteriorating neurology requiring urgent surgical evacuation. Smaller stable bleeds can be managed conservatively, allowing clot liquefaction over 7 to 10 days for less invasive bowel drainage. Subdural blood spreads diffusely across the brain, giving a concave appearance due to the less adherence between the dura and the brain. Clotting abnormalities should be corrected where possible. So this image again is illustrating our subdurals. The first image here is showing a right-sided acute subdural hematoma. You can see the hyperdense mass here with midline shift. So there is also brain swelling because we have lost the gyri. We cannot see the gyri here. So this indicates that this was a high energy injury. So the second picture here is showing a bilateral subdural hematoma with mixed density hematomas. So the hypodense material represents old blood, and the higher density indicates more recent bleeding, probably loculated bleeding, so it requires craniotomy to evacuate. So the bleed on the right is isodense, indicating intermediate. So there is a bleed here. This is brain here. This is the junction between the bleed and the brain, and just immediately outside of it there's another layer, but it has the same density as the brain. So that is subacute. Then this one is this one is more dense. The brain is more dense than the hematoma on this side. So this is old blood. So like doctor had asked how to distinguish a chronic from an acute one and from the subacute. They're actually represented in these two pictures. All the three scenarios are represented. This one is acute, this is chronic, this is subacute. I hope that is clear now. So the patient presents with confusion, disorientation, gradually with altered level of consciousness and drowsiness. Later we have convulsions, features of increased intracranial pressure, and features of coning that may develop that we had discussed previously. So you might also have papillary changes. So treatment we have said is craniotomy and evacuation of the clot when required on both sides. Sometimes can be done on both sides if indicated. Give antibiotics and anticonvulsants, long-term anticonvulsants actually. Some literature says 3 years. Complications, you can have epilepsy, meningitis, neurological deficits, or you can even have surgical site infections. So that was epidural and subdural. So now talking about the...
Hello?
Yes, please. Am I audible?
Yes. So what the treatment for the acute subdural hematoma? The surgical management, the procedure of choice for acute subdural.
We said craniotomy, doctor.
Then for the chronic,
we said depending on the symptoms, we can do conservative, or still we can do craniotomy.
no. So for chronic, you do bar holes, isn't it? For the chronic subdural. Then for acute subdural, you do what? You do a craniotomy.
Okay, doctor.
And how is the prognosis of patients with epidural hematoma and the subdural hematoma? The acute ones. Someone is having acute epidural hematoma, another is having epidural hematoma. Which one will be having a worse prognosis?
So the people with acute subdural hematomas actually have a worse prognosis than the ones with acute epidural hematomas if surgical intervention is done in time.
Why?
Why is because these, we have already said that these subdural hematomas, the first category of patients that we have are the ones who are involved in high energy impacts with associated other intracranial hemorrhages with an impact on the brain, and this bleeding is from the cortical blood vessels. So I would imagine that the extent of the trauma in the subdural is actually bigger than for epidural mostly.
So the subdural involves what? It's a more a brain injury, then the epidural finds more what of the scar injury. So we
Yes,
have more of the brain involvement in what? In the subdural. And that's why the prognosis of patients with acute subdural hematoma is worse than that of what? Of epidural hematomas.
Yes, doctor.
You are going to read about the steps of what? Of the formation of the transformation from acute to the chronic subdural hematoma. There are basically 4 steps that the hematoma transitions from being acute to the chronic. So read about those 4 steps of the chronic subdural hematoma formation.
Thank you, doctor.
You continue.
Yes. So that was on epidural and subdural hematoma. So we will continue and now look at the traumatic subarachnoid hemorrhage. So for subarachnoid hemorrhage, trauma is the commonest cause, and it results from tears in small veins in the subarachnoid space. The aneurysmal subarachnoid hemorrhage also is there, but trauma is the commonest. So there will be vasospasm. Some people are able to identify that vasospasm on the CT. So CT angiography may exclude spontaneous subarachnoid hemorrhage causes. So we said trauma is the commonest cause of subarachnoid hemorrhage. So the image on the right upper corner is illustrating a subarachnoid hemorrhage. If you can see, it has an arrow in the image, and where my pointer is, it is having a subarachnoid hemorrhage. So so that is a subarachnoid hemorrhage. The other one is the cerebral contusions and intraventricular bleeds. The cerebral contusions and the intraventricular bleeds, these usually occur when the accident has occurred and then the brain shakes or moves around over the rough surface of the skull base. So usually they are seen. Yes, doctor.
Yes. Did you talk about people who are at risk of getting these chronic subdural hematomas?
Yes, we said we said alcoholics, we said people who are elderly, and we said people who are on anticoagulant medication.
Okay, that's good. Then the subarachnoid hemorrhage you read about is the grades, isn't it? You read about the grading of the subarachnoid hemorrhage. It's called the Fisher grading of what? Of subarachnoid hemorrhage. It is graded. Yeah, so what's for level you have to know all those details. Eh? So read what we call the Fisher grading of what? Of the subarachnoid hemorrhage. You continue.
All right. So now we are looking at cerebral contusions and intraventricular bleeds, and we've said when the brain, the accident occurs and the brain moves over the rough surface of the skull base, usually creates these contusions. So it commonly affects the frontal, parietal, and occipital lobes, and largely it is conservative management. We have seen many of these patients on our ward with these contusions, and they are being managed conservatively. So large intraventricular bleeds, they require surgical evacuation because they can block CSF flow, and they can actually cause increased intracranial pressure, and you have to evacuate them. Surgical decompression is often necessary in patients when the traumatic intraventricular hemorrhage exceeds the volume, if it exceeds 50 mils, or if the patient presents with a GCS of 6 to 8 with frontal or temporal contusions which are more than 20 mils in volume, with midline shift of greater or equal to 5 millimeters, and or cysternal compression on CT scan. So
Hello?
that, yes.
Then you also take note at times people confuse the contusion and concussion. So what are the differences between a contusion and a concussion?
Concussion. So for a contusion,
Dr. John,
yes.
sorry, I have. How can I differentiate in the CT scan brain contusion and subarachnoid hemorrhage? They look like the same way in CT scan, and also in the ventricular hemorrhage, the blood it can't drain to the ventricular for normally in the CSF its drain is up to the spinal cord, like that drainage that way. So the blood it can't drain like the CSF.
Okay. If you look at the CT images that I have shown in this presentation, the contusion can never, and it cannot be confused with a subarachnoid hemorrhage. A subarachnoid hemorrhage, I showed you a picture here. You can see, you see this, do you see my arrow? Where it is? Abubakar, do you see my arrow?
No, I did not see.
You are not seeing my cursor?
You can move. I did not see your arrow.
In the upper right image
Okay.
of these two images, you see the upper one?
Yes.
Do you see an arrow in that image?
Yes, with the small hyperdense.
So that is a subarachnoid.
Okay.
So now below that image, do you see where there is a cursor, where there is an arrow?
Okay.
Mine, the one which I'm moving. This one.
No, I didn't see.
You don't see. So, but
Yes.
again, do you see the image below and the image above? Do you see any
Yes.
confusion?
Yes, I see this hyperdense, the big one.
This one. That one is
Yes,
that one is an epidural.
okay.
But on the opposite side of the big one.
In the brain, in the
Yes,
parenchyma.
inside the parenchyma.
Okay.
So now when we go to the next slide, do you see the picture above inside of the
Yes.
brain parenchyma? That's a contusion. Do you see that? So there is also yes, there is also another one which is inside of the ventricle. Yes. So they cannot be confused. They are really, really different. So the other question was what?
The ventricular drainage. It is not. It can't follow the way of the CSF drainage when the blood in the inside of the ventricle.
This is clotted blood. This is clotted blood. CSF is clear fluid. You know it. So it cannot move.
If it's a fresh, it's a difference.
Come again?
If it's the acute or fresh blood, fresh.
No, it is clotted blood. It is a hematoma.
Okay, you can go, bro.
So
Thank you.
the densities of blood and CSF are different, isn't it? Whether it is fresh blood or chronic, still it will be different from what? From CSF, so they can't appear the same on the CT scan.
Okay.
So the difference between the contusion and concussion.
A concussion is a brain shake. Well, a contusion is a bruise within the parenchyma of the brain.
So can you see a concussion on a CT scan or not?
No, you cannot see a concussion on a CT scan.
So a concussion is what? Is microscopic. Then a contusion is what? Macroscopic.
Yes, doctor.
And you take note, the contusion tends to be more associated with other neurological deficits, and like what? And like a concussion. You continue.
Thank you, doctor. So now the other lesion we will focus on is the diffuse axonal injury, which results from high energy accidents that renders the patient unconscious. So what happens is that there is a rotational acceleration-deceleration injury to the white matter pathways of the brain, leading to loss of consciousness in a TBI patient. But in this case, we don't have a mass effect or a mass lesion. We don't have those herniation syndromes and so on that we have been talking about. But there has been an acceleration, deceleration, or rotation injury to the white matter. The white matter components of the brains, they are the tracts or the fibers which are taking information from the different parts of the body and the different parts of the brain. So you typically have a patient on the ward, and the patient is having reduced consciousness, or they lost their consciousness, and then you do a CT scan, and you are not seeing anything. You're not seeing any mass lesions. It essentially looks normal CT scan. So that is when you suspect that this patient actually is having diffuse axonal injury. So the CT scan findings do not match the patient's clinical neurological status. So diffuse axonal, yes.
The CT scan will not be normal, isn't it? It will be, you'll be seeing what? There will be cerebral edema, ischemia, but not what?
No mass
Don't be
vision.
showing no pictures of what of the city. So be seeing what major what ischemia, edema, but you will not be what appreciating. Don't be those hematomas. Then you take note. These are patients like if you have like patients of severe injury, like more than 50% of them will be what having diffuse axonal injury and has a very poor prognosis. Because majority of those patients, like 90%, they will remain what in a state of vegetative what. They'll be more like in a vegetative state, like more than 90% of what of these patients. So it has what it has a poor prognosis compared to those of maybe PQ or sub-Q. You continue.
So thank you, doctor. As you have enlightened us, you see other features of cerebral edema, whereby you are not seeing the gyri, and the patient has a very poor prognosis.
So remember, this patient shouldn't be managed on the ward. Those patients with what diffuse axonal injury, they should be managed from where? From ICU. So if you make a diagnosis of diffuse axonal injury, then the best should be for the patient to be transferred to ICU, not on the ward. You continue.
Thank you. So it is a pathological diagnosis at post-mortem most of the times, but hemorrhagic foci in the corpus callosum and dorsolateral rostral brainstem may be suggestive on the CT. So that was diffuse axonal injury. Now we will talk about injuries to the blood vessels in the brain. So you have arterial dissection, whereby you have separation of the blood vessel layers with accumulation of blood in between the tunica adventitia and media, creating a pseudoaneurysm. You commonly injured vessels include the vertebral artery, the common carotid artery, internal carotid artery, and the internal carotid artery. So these are usually associated with other injuries, especially in the neck region, and the patient will present with headache, neck pain, and focal ischemic deficits due to occlusion by neurohematoma, thrombus, and thromboembolism. So the blood supply to the distal parts that are supposed to be supplied by these blood vessels is cut off, and you have ischemia of those parts, and then the patient presents with deficits in the areas which are supplied by those blood vessels. So the other specific injury that we will talk about is the pituitary dysfunction, which is common in skull-base fractures. So the pituitary itself, it can get injured, or the pituitary stalk, it can get injured. So when that happens, you remember the role of the master gland. You have almost all the hormones being affected, and the patient presents with the associated endocrinopathies. More commonly, we have antidiuretic hormone impairment, which leads to diabetic insipidus and hypernatremia, or a poorly understood salt excretory dysfunction that manifests as syndrome of inappropriate ADH secretion and the salt wasting syndrome. So that leads to water retention and hyponatremia in the patient. So I don't know if Dr. Daniel could help us understand more about this syndrome of inappropriate ADH secretion. I really didn't conceptualize it well. I don't know if other members have conceptualized it in the context of brain injury. Maybe it is a subject of further reading. So the complications of head injury, they include So the complications include early complications and late complications. The early complications could be compression of the brain neurovascular structures, leading to herniation syndromes and CSF leakage in open head injury, which is the biggest feared risk here is meningitis. You can have pituitary failure. You can have early post-traumatic epilepsy. Among the late complications, you have chronic subdural hematoma. You have late post-traumatic epilepsy, post-traumatic amnesia, post-traumatic headache, and secondary hydrocephaly. You can even have impairment in the brain as a complication of head injury. So, so that marks the end of the presentation, and we can have other comments. I thank you for listening to me. Yes.
So you are also part of what the prognosis of these patients of head injury, isn't it? And also the scoring system of the outcome of these patients. Basically, you have heard how this GCS is what they call what the Glasgow outcome score for these patients, like those who are talking, maybe like those who like physical injury, some of them they might not die, but they can have what like severe disability or the remaining percent vegetative state. So find out the scores that are given to those patients.
Yes, doctor. Yes, we didn't talk about it, but there is the so-called Glasgow. There is the so-called Glasgow outcome score, which measures functional outcome of patients who undergo traumatic brain injury. So it has 5 parameters whereby
so you are going to read my back is going to. You are going to add it in your slide, then you prepare for burns and we cover it this week.
All right, doctor.
Okay, it's fine. Thank you. Let me prepare neat cover.
Thank you, doctor.
Okay, nice day.
Thank you. Safe journey.
Okay, thanks.
Thank you, Doc.
Thank you, members.